And I'm delighted to introduce our first speaker for this session. It's Dr. Andrew Fletcher, and he's a consultant haematologist in Hull. So Andrew started training in Aberdeen, and it was on a medical elective that he did that he came across paediatric haematology. And he's done some work there, and ideally wanted to be someone to cure the paediatric leukemias. Okay? He's had a consultant job in Chesterfield, as well as the one in Hull, and I'm delighted that he's here today. He's been clinical director of pathology, and he has been the clinical lead for obstetric haematology. How awesome would that be? So again, Hull are very lucky to have that. So in amongst his current research that he's doing and his service development and improvement, he's also doing an MBA in leadership. So he's given a job to a busy man.
Thank you very much for inviting me. I'm not quite sure how I got invited, but I'm sure Perva will take the blame. During the MBA I'm doing, one of the guys teaching us are really keen that we try and tell stories, and I've only got one obstetric anaesthetic story. When my son was being born, his mum threw up all over the anaesthetist that was putting a cannula in as she was being wheeled for an emergency section. So that's the only time I've had anything to do with obstetric anaesthetics, apart from in the clinic I do in Hull. And for the past 3 or 4 years I've done a once a month clinic with an obstetrician and sometimes with an anaesthetist that swans in and swans out and saves the day. We've had some brilliant cases that some of whom I'll go through today, and if we've got time I'll talk about one of the most interesting patients I've had to deal with in the whole of my career that was a real challenge. So we're going to talk about anemia. I know anemia is maybe a bit boring, but it is really important. We'll go on to sickle cell disease. We've got 12 sickle cell patients in Hull at the moment, so it's not big in our workload, but it can cause a huge amount of problems. Over this side of Yorkshire, it's much more important, and if you're ever in Birmingham or London, it's huge. We'll talk a little bit about coagulation. The coagulation links everything to do with haematology and obstetrics, so I can't get away without talking about the coagulation cascade, at least for a few minutes. Thrombocytopenia, everybody always wants to know about low platelets and what causes it and how to manage it, and there's a few good stuff, a few good guidelines coming out about that. And then maybe if we have time, an interesting case at the end. There's recurring themes through all of this. Pregnancy causes all sorts of bother for the haematological system, the full blood count, the coagulations system, and we'll talk about that. And these interactions are really complex, but I'm going to try and make them really simple, because haematology is very simple. So here we go, here are my rules of haematology. If it's low or absent, replace it. If it's high, reduce it. If it's cancer, give chemo. There are only 16 things that go wrong in haematology. Red cells, white cells, platelets, and 13 clotting factors. So it is a very simple specialty. So anemia. Haematological causes of anemia are really rare. Primary leukemias or bone marrow failure does not really happen. But anemia of chronic disease is really common. Iron deficiency is equally common. And then kidney disease, as you get older, is the third commonest cause of anemia in the UK. And this is data that was published in NICE a few years ago. And B12 and folate deficiency also sneak in there up in the top 5. So you've got to treat the cause. And for obstetric patients, anemia is really, really common. There's huge problems in how you assess someone to be anemic, especially when you're looking at iron deficiency. We all get trained to look at microcytic hyperchromic anemia, but when your MCV is normal in 30% of the patients with iron deficiency, it's a completely useless bit of the full blood count. And you can argue that actually when we put a full blood count out, we should put a hemoglobin, a white count and a platelet and nothing else. People misinterpret it and don't know how to use it very well. When you're diabetic, when you've got a paraprotein, when you've got red cell agglutination or hemolysis, your MCV goes up. And all the indices we use in haematology look at the average of the hemoglobin or the red cell lifespan over 120 days. So they're all just an average, nothing specific. So when you get pregnant, it gets even worse. You dilute your red cells, white cells and platelets, you get macrocytosis. You dilute your platelets even more. You also get a neutrophil in thrombocytosis because you're trying to protect yourself and your fetus from infection. And your parasite takes everything until it leaves home. So iron, B12, folate, food, money, the car, and everything else. And that never finishes. I know because my mum is still being sponged off by me. So, some interesting cases. I was to talk to the obstetric team in Hull one day, and they phoned me at 9 o'clock in the morning saying, Andy, you're talking to us this afternoon, but we've got a real problem. We've got this woman who's really sick. So she was 32 weeks pregnant. She'd got a history of bleeding and bruising at the end of her last pregnancy, and it was happening again. She'd had genital herpes, so what? She had a bit of proteinuria. That always makes me worried when obstetrics phone me with proteinuria, and I want to run away, put the phone down and go and hide. She'd been admitted to the labour ward with a fever and not well. So this is a full blood count. We have a really antiquated DOS-based lab system in Hull. This is what we look at all the results for. So it looks really basic, but it's really, really good at getting information. We've put the beautiful Lorenzo system in. Enough said. So this lady did have a normal blood count, but she was very much not normal on the 25th of May last year. She was very anemic and symptomatic with that. Her white count was just okay, so she was almost pancytopenic, but her white count was 0.5 too high. And the platelet count was falling. Looking at her blood film, as we do in haematology, there were no fragments, so it didn't look like TTP or microangiopathic hemolytic anemia or sepsis. She had funny-looking teardrop cells, lots of basophilic stippling, which basically means your bone marrow is stressed out and not working very well, and she had hypersegmented neutrophils. So this lady was sick, but the blood picture was probably one of B12 or folate deficiency. So her reticulocyte count was low, so she basically had bone marrow failure. Something was stopping her making red blood cells. Her reticulocyte hemoglobin, or HE, I'll come back to a bit later on possibly, was slightly high, so she could respond, she can make a response, she's just not making a very good response. Her renal function was reassuringly normal, so this wasn't going to be a leukemia, and her LFTs were normal apart from bilirubin. And when you've got B12 or folate deficiency, you can get a really profound hemolytic picture. So here we go. So just even before we got these results back later in the day, before I gave my talk to the obstetricians, we had a really low B12 come back, also a really low folate, but her ferritin was all right. So this lady had a really, really bad whole diet. So fish fingers, chicken, and potato in whatever form you can find. So B12 deficiency causes profound cytopenias in extreme and hemolysis. You give B12 and folate to work better together. Hemoglobin starts to improve in 24 hours, and you measure that with the retic count. You try not to transfuse these guys. This lady was in labour, there was concern about her, so we did top her up. So that, although it looked really bad when we first got the phone call, very quickly, by sort of within 4 or 5 hours, we had a diagnosis and a treatment plan, and this woman went on to deliver a nice normal baby. So in the obstetric clinic I do regularly, we see this sort of thing. We see young women in their first or second pregnancy, it gets worse as they get more pregnant, more pregnancies. She was a little bit anemic, but she had a high platelet count. High platelet count can be really important. Usually it's nothing to worry about. She was a bit microcytic, but her MCV, the MCH is 29, not the MCV. So her ferritin was 3, and if you look across Yorkshire and the east, and especially in the west, in Bradford, we really don't like eating anything with iron in it. Red meat in whole is expensive apparently. People don't like the taste of it, they don't eat it. There are 2 signs of madness. I apologise right now for offending everybody. Vegetarianism first and veganism second. Especially if you are a growing female who's just about to have periods or having periods, or if you want to have any parasites, you really do not want to have a ferritin less than 50. All the stuff that's in the media at the moment about how bad red meat is, I'm the only person that stands up and says, ignore all that, eat 2 steaks, two portions of red meat, beef, liver or lamb a week, some fortified cereal, and you will not get iron deficiency, unless you've got bowel disease. So this girl had iron deficiency anemia, really easy to sort out. All we need to do is educate primary care that thrombocytosis is usually caused by iron deficiency, give some iron and sort it out. So, anemia diagnosis is a real nightmare, especially in Hull. We did a population-based study in the lab looking at everybody's normal ranges. So we looked at all the full blood count indices, we looked at iron, we looked at B12, and your average ferritin in Hull and East Riding is less than 15. So the whole population, by normal definition, is iron deficient. So, do we treat everybody or do we target the ones that need to be treated? It does mean we are doing an absolute huge amount of endoscopies, but that's another story. So your ferritin will be low before you get anemic, and anemia is the last thing you get when you are iron deficient. Ferritin is rubbish to be measured at pretty much any time, apart from when you're completely well. If you're pregnant, your ferritin is artificially raised by about 30%. Everything else also increases your ferritin. So any infection or inflammation, you really should either measure a CRP with a ferritin or ask a patient if they have any chronic disease, because all of these things push your ferritin up. So a ferritin less than 100 can't actually exclude iron deficiency. Also, ferritin is a rough and ready measure of your iron, which is important for red cells. It's also important for your neurons. It's important for the lining of your gastrointestinal tract. It's important for wound healing. If your ferritin is less than 50, you get fatigue. So if you are iron deficient with anemia, you're knackered because you're anemic, and you're knackered because of your iron deficiency, and you need to get your ferritin above 50 before you start feeling normal. When they do sort of quality of life type studies, a ferritin of 50 and a hemoglobin of 10 are where the cutoff is for fatigue. Also, the bottom right picture is meant to be a picture of the female genital tract. I thought I'd be more polite than I might normally be. But you need ferritin and iron to replace the lining of your uterus and the lining of your vagina and your cervix. It's really important. So iron deficiency causes all sorts of other bother than anemia. So this is just, we've made 2 anemia pathways in Hull. The first one was thrown back at us from the labs because it was too simple. It put everybody into 4 groups using a hemoglobin and ferritin. Medics, especially the physicians, are really anal. They wanted the MCB, MCH and every other bit of the full blood count to be taken into consideration. So a 2-pronged attack using a hemoglobin and ferritin to categorise someone's anemia wasn't good enough. So we went the other way and made an 8-page anemia pathway and were told it was too complex, but it told everybody exactly where to push their patients. Part of that work was to do a review of everything that causes an artificially raised ferritin or anemia of chronic disease, and it's all those conditions on the right-hand side. So almost every condition can cause anemia of chronic disease, and if you've got any of these in a hemoglobin above 90, you probably don't need to worry about it. And you definitely don't need to send them for an endoscopy. So anemia occurs in population studies between 25 and 92% of patients who are pregnant, iron deficiency in about 25% of patients. There's no clear cut-off for a hemoglobin that causes risk in pregnancy, but it does cause low birth weight, it causes prematurity and maternal and fetal mortality. There's stuff going on in the press that suggests that we should give iron to everybody. That's probably not the case, but we need to think about how we measure iron in women properly. And there's no good evidence about this. So some places like Leicester and Oxford are now giving iron to everybody. There's no clear effect on outcome, but we're trying to do a project in Hull with one of our lab scientists that looks at all of this, that might shed a bit of information on how to test for iron deficiency in pregnancy and how to monitor it. If you have multiple pregnancies or pregnancies in close succession, your ferritin goes down step by step, and after 2 or 3 pregnancies and in Hull where there's no iron, you have very iron deficient mothers and very iron deficient babies. So where do you set the bar for transfusion or managing haemoglobins. PPH occurs in about 0.5% of women, or causes premature death in 0.5% of all the premature deaths, if you look at trauma being the top. So PPH is up there and still quite common worldwide. When do you transfuse? If your hemoglobin is less than 100, you could argue that's when you start getting fatigue, that's when you should transfuse. None of us do that. There's good evidence that it makes no clinical difference when your hemoglobin goes down to about 70, and all of the stuff you guys have done in critical care has shown that. But your fatigue with a ferritin of 50 and a hemoglobin less than 100 is quite profound. We still transfuse at 80 in haematology, but 70 is probably a better way to do it. The best transfusion is one avoided. So how do you stop or prevent bleeding? Stop all the drugs you can. In pregnant women, stopping their antiplatelets that have helped them get pregnant because of their recurrent miscarriage is really difficult, so we tend to ignore it. Stop your anticoagulation. So low molecular weight heparin, ideally stop prophylactic doses 12 hours before anything. So as soon as a woman comes into labour ward, stop it. That might give you enough time to not have to worry about it. Therapeutic low molecular heparin, ideally stop 24 hours, which is more challenging. The DOACs I'll come back to, but the guidance is pretty much to try and avoid them. I hate all these new anticoagulants. I have not grown up with them. I don't prescribe them. I have to get people out of trouble when patients are bleeding with them, and basically you just follow the local guidelines that should have been written for all of these things based on the BCSH or BSH guidelines, but they are a complete nightmare. Coagulation disorders are very infrequent, but also challenging, and rely on a multidisciplinary team of an obstetrician, a haematologist, ideally you guys in anaesthetics coming in and seeing these patients with us and making a detailed plan that gets published for everyone to see. And communication is really the key for these guys. Factor IX deficiency, or Christmas disease, one with haemophilia B, the carriers of this condition, factor IX is one of the few clotting factors that does not go up through pregnancy. So these guys, if they have a low factor IX, it stays low most of the time, and they do need factor IX replacement when they go into delivery. And sometimes these guys get missed and can cause concern in the middle of a Friday night. ITP and acquired bleeding disorders are more challenging sometimes, or more common. I'll come back to those as well. So, DOACs, this is just a very quick slide that I found this morning from the ISTH. Patients on DOACs who want to be pregnant, counsel them against it and get them on contraception. Rabbits are the main studied animal for the side effects of DOACs, and in rabbits they cause reduced fertility, reduced implantation, pregnancy loss, all of these things, so they're thought to be bad. In humans, they do cause some problems, especially rivaroxaban, but the evidence is very small. Try and change them to an alternative. Warfarin is safe if you're more than 6 weeks pregnant. So warfarin you can use throughout pregnancy, and it means you don't have to have lots of injections other than your INR. And you can't breastfeed on these drugs either. So DOACs avoid. If you have to reverse them, please look at your local guidelines because they keep changing. So preventing bleeding again. Tranexamic acid, big in the press again. Driven by surgery and you guys in anaesthesia. It's an antifibrinolytic. It does not cause an increased risk of thrombosis in pregnancy or trauma. It does have good efficacy in bleeding, but in trauma, the CRASH 2 study showed bleeding is reduced by at least 30%. It reduces mortality. It has the most benefit in massive transfusions. I've not talked anything about the massive transfusion policy because everywhere is a bit different. Some people love it, some people hate it. Basically, we swapped from whole blood, which had a bit of everything in it, to packed red cells, platelets, FFP and cryo, and now fibrinogen concentrate is going to be the new kid on the block. You need to give a bit of everything to make it work, and I'll come back to that because platelets are probably the most important central bit of the coagulation cascade. The cardiothoracic guys have used a lot of tranexamic acid. It reduces mortality in transfusion. It doesn't seem to work so well in neurosurgery or after intracranial hemorrhage. In pregnancy, if you give it to everybody like the French did, it makes no difference in outcome or PPH rates. But if you treat women having a PPH and you give it within 3 hours, there's a 19% reduction. And the woman trial was an international first world and third world study, which is really good, very big, and showed this is really good as long as you can get IV access and deliver the drug, which was the one failing. So if you're in the middle of Africa with no IV access, it's not so useful. So in Hull, we're doing loads about anemia in pregnancy, where you've done a master's degree looking at some of the new red cell indices that you can get on the analyzers but not see in the real world. And reticulated hemoglobin is basically the hemoglobin in the very immature red cells as soon as they fall out of the bone marrow. That shows what your hemoglobin is like there and then on the day, and your iron status there and then on the day, rather than an average like everything else we use. We're doing a PhD looking at all the red cell indices and hematinics and iron studies that you can cheaply do in a normal lab. That should be useful. And we're also trying, with one of the students, looking at hemoglobin and iron studies in multiple pregnancies, just to prove that it actually does fall rather than just going on gut feeling. I've talked about the anemia pathway, which is useful if people will read all that results. So the third case to talk about is a 29-year-old from Sao Tome in Equatorial West Africa. She came to the UK via Portugal. She was very well. She'd had one child in Portugal as she travelled to the UK. She came at 18 weeks gestation. She was perfectly well, very tall, very slim lady. You wouldn't know she was 18 weeks pregnant, and in fact when she was at term you wouldn't have known she was pregnant either. Antenatal screening, she was found to have hemoglobin SC disease that she did not know about, or she claimed not to know about. So sickling conditions go from homozygous hemoglobin SS sickle cell anemia right through to hemoglobin C, hemoglobin E, hemoglobin D Punjab, and if combined with beta thalassemia major, it's even worse and causes more problems. So these are all the sickling conditions. Hemoglobinopathy carriers are nothing to worry about. They can be treated as normal, but they do have a slightly increased risk of UTIs, especially those carrying hemoglobin S and hemoglobin C. These sickling conditions, so the guys on this side, including hemoglobin C, you get a chronic hemolysis, reduced hemoglobin solubility, you get inflexible red cells that get clogged up in the small circulation, you get renal insufficiency, you get cardiac disease, respiratory disease, and bone disease, several of which can knock on and affect you when you're pregnant. Guys in St Thomas's have got the biggest sickle population in the UK and have got the best guidelines I can find about these. The guys in Sheffield, led by Josh Wright. Josh has amazing experience of these guys coming from Birmingham as a trainee, so he's my go-to person about sickle cell patients. So these guys need to be kept warm. They can have all these complications, and basically their sickle cell affects the mother, which then affects the baby, but also vice versa. The baby being pregnant with sickle cell disease feeds back and makes sickling worse. So you get a vicious circle, not just the badness. And the wheel on the right is basically how severe things are, or the more likely they are to have complications. With hemoglobin S beta thalassemia being the worst, and hemoglobin SS being second worst. So you need to review these women more frequently. You need to check the partner to see if the baby's going to be affected. You need to make sure they're not immunosuppressed as much as normal, so on penicillin. They need to have a VT assessment. If they have any risk factors, treat them with low molecular weight heparin. You need to do their regular growth scans and their 20-week anomaly scan, and admit these guys if they have complications. They're everywhere that sees these patients more than whole will have a better policy and a better idea of how to manage them. So you can transfuse these women or exchange transfuse them if they are having problems. If they're on hydroxycarbamide, which pushes up your fetal hemoglobin and protects you, the guideline now says to carry that on through pregnancy unless people are really, really worried about teratogenic effects, but they're not as bad as people all say. And there is no risk of leukemia with hydroxycarbamide in sickle patients. After delivery, stop these women having more babies until they plan them, ideally with your help. especially the obstetricians. So this woman, she came in at 18 weeks and said, I'm not having any more care, I'm not having my scans, I've had my first baby without any problems, all my friends with sickle cell disease have never had any problems, I'm going away, I'll come back when I'm in labour. She refused absolutely point blank to do anything we asked her. She came in labour, 39 weeks, popped out her baby, walked out on early discharge, and occasionally comes back to see us in haematology, completely disproving all the stress that we have over sickle cell anemia in pregnancy. However, I had another girl that was up here at university, had every complication known to man, and was really sick, including during her delivery, after which she had an exchange transfusion in London. So luckily she went home back to where they know what they're doing with this condition. So, you couldn't get away with haematology talk without the coagulation cascade in all its glory. I will simplify it for you. Andy's version is much better and much more useful. So any red cell problem causes inflammation in the blood vessels, which then releases tissue factor from the damaged blood vessels, and that triggers your coagulation cascade. So there's a massive link between red cell disorders and coagulation, which we're starting to understand a lot better. Coagulation is really simple. You start with any tissue damage, that releases tissue factor, which activates factor 7, which comes down and gives you a little bit of thrombin, which feeds back to factor 8 and 9. You get a massive explosion, which then sticks to the platelets, and the platelets are your train track for all your clotting factors to work on. So no platelets means no coagulation and lots of bleeding. The train track makes the TOAs, the prothrombinase, you make your fibrin, which sticks to platelets, and you get a nice clot. Really simple. Von Willebrand factor links the platelets with your damaged tissue and your factor 8, so it pulls in all the bits of the clotting. So if you have no von Willebrand factor, like in von Willebrand disease, or it doesn't work, you don't clot, just like you have no platelets. So that's coagulation in a nutshell in 2 minutes. Your natural anticoagulants are all messed up in pregnancy, so your antithrombin works on your thrombin, it works on protein C and protein S and factor 11 and 9, sorry. When you have a baby, it sits on your left femoral vein, and that's why you get more blood clots in your left leg that then spread to your lungs, giving you PE. All of these drop when you're pregnant. All the clotting factors, apart from factor 9, go up when you're pregnant, and that's why you get more thrombotic events when you're pregnant. If you then add in these weird things called thrombophilia that you don't need to test for anymore because they're really common, you clot when you're pregnant. So this is just a picture of how things changed. The factor 9 is really variable. We've got 2 women with factor 9 deficiency or carriers. One completely normalised through the pregnancy and one did not. And she bled like a stuck pig when she decided to have a baby one night at the weekend. So blood clots after delivery go up, depending on your type of delivery, increases. So if you have a planned, normal delivery versus a section versus an emergency section, increases your risk of blood clots, and that's why we prophylact these women as they go home. So, coagulation problems in pregnancy, thrombocytopenia, thrombosis, coagulation factor deficiency. How am I doing for time? So, this next case, 32 weeks gestation, 3rd pregnancy, had a similar pattern every time. Her white count was going up, which is quite normal in pregnancy, it's nothing to worry about. Platelet count was always a little bit low, but above 100. Oops. So this is gestational thrombocytopenia. If your platelet count is above 80, you don't need to worry about it. It's not clinically significant to mother or baby. You do not need to intervene. However, when your oncology pharmacist that normally comes and tells you off for prescribing chemo wrong walks in to see you in an obstetric clinic, things are always going to be completely different. So this lady's platelet count gradually slipped from slightly low to more low, and then she went into spontaneous labour with a fall in platelet count. She hadn't responded very well to steroids, she didn't respond to intravenous immunoglobulin, so we had to give her platelets late one evening. These things always happened in the evening. I don't know why, but it always does. So, platelet count 75 to 80. If you're North American, the guidelines say 80. In the UK, depending on where you are, it will say 75 or 80. and you don't need to do anything. Platelet count above 75, below 75, try to give steroids if you have time. If you are running out of time or have run out of time, give intravenous immunoglobulin and get a delivery plan from us in haematology and the obstetricians so you guys can safely do what you need to do to get this mother through her delivery. So immune thrombocytopenia may be due to a chronic ITP or maybe brand new. It has an effect on mum and baby. So 15% of babies with moms who have ITP are also affected with thrombocytopenia and can have intracranial hemorrhages. You can give intravenous immunoglobulin to new babies if they are bleeding, and that just grabs hold of the IG that's across the placenta. You need to communicate, like the bleeding disorders. It's all about talking to each other and making things really clear for us, the midwives and the obstetricians, and try and avoid all the things that damage babies' heads that we like doing. So usually ITP is pre-existing. It might be newly found, but if you go back in these women's full blood count, you often see that they've been thrombocytopenic for a long time. Sometimes gestational if it doesn't drop much below 100. Might be something more autoimmune like lupus, which is really rare. Acute onset thrombocytopenia in pregnancy is not usually ITP. Might be HELLP syndrome. I hate it. It causes lots of problems. Acute fatty liver of pregnancy, you've got a poster of about, and I've never seen it before, so that's a new one on me, so well done for seeing that. TTP and HUS are vanishingly rare, but do happen, and they're awful when they do happen, and infection is much more common than we think, as is HIV probably. So, what can you do with a low platelet count? If your platelet count is above 50, it is safe for the obstetricians to cut into this lady's belly and do a cesarean section. I'll come back to that with provider in a minute. You should try and avoid platelet transfusions in ITP because you've got antibodies to platelets, so you use them up really, really quickly, and they don't really work. So, what can you guys do and when can you do it? If you look at all the evidence, and there's some really good reviews out there now, epidural hematomas have not been reported in obstetrics. There's a surgical case, the lowest platelet count reported is 71. That's probably why we've picked a random number of 75 in the UK, and the risk-averse Americans have made it 80 for when you can put an epidural in. Urexil, I'm afraid you guys will have to sit me down at lunchtime and tell me the difference between these two things. If you have preeclampsia, you need to do something completely different. I'm going to have to move on quickly. Justin Bean has put this lovely review out a couple of years ago. It's quite old now. He's the most sensible haematologist in Sheffield for a long time, and these are really good guidance on when you can and cannot do stuff. So very quickly, this is the most interesting case I've seen. 23-year-old, recently moved over from Poland. She's in a second pregnancy, no past history. She presented with thrombocytosis, which of course was going to be iron deficiency in Hull. However, she had a basophilia, which is a bit odd, but she didn't at this point. So at 28 weeks, she did have a basophilia, and her platelet count was going up to 690. She also had lots of neutrophils, and you can't get away in a haematology talk without some pathology. She had what looked like chronic myeloid leukemia in chronic phase on her blood count, and this was the trend of, she was diagnosed with CML because she had the Philadelphia chromosome. She started imastinib because they were concerned she had polyhydramnios and her risk of thrombosis was going up, so we decided to treat her. She delivered at the end of November 2 years ago now. She had a cesarean section for fetal distress. She got a wound infection next week and started metronidazole and flu clots, and then she went into formal liver failure. She had a liver transplant on the 4th of January last year after having her second baby and being told she had cancer. This was felt to be multifactorial, probably because of the imatinib and everything else. So after she was immunosuppressed because of her transplant, we just sat on her and she slowly relapsed. We asked everybody known to man about what we can do. So we restarted a different tyrosine kinase inhibitor that doesn't cause liver impairment, and she's finally gone into a major molecular response post-liver transplant. She's the second patient in the literature to have been described with liver failure post-pregnancy and has had the best response. So one of my colleagues presented this at BSH a few weeks ago, so we're going to try and publish this one as well. So thrombocytosis is usually iron deficient, but occasionally something really, really rare. When it's really, really rare, it's really, really bad. So that's my really quick run through obstetric haematology for anaesthetists. Any questions?
Thank you, that was very interesting. Years and years ago, before we had platelet concentrates and IVIG and things, if people had platelets of about 80, 70, 80, and we were thinking of doing a block, we use DDAVP to try and improve its functionality. Do you still do that?
We don't, unless you've got a platelet disorder or von Willebrand's, just because of the side effects, and everyone's become very risk averse in haematology. You can use it. There's Beverly Hunt had written about that not too long ago, saying it was still a useful thing to try. And basically, you pull all the platelets into your circulation, you massively increase the von Willebrand factor, and you give DDAVP or desmopressin, as it's called now. And it does work, but we don't like doing it because it makes people have headaches, it can cause funny fluid shifts, and people just get anxious about it. So it's not in any of the guidelines anymore, but it did work, and Beverly Hunt in London does say it's something to go back to and consider because it is fairly safe. But you have to watch someone's fluid balance quite strictly because of the problems it causes. So yeah, it's a good old-fashioned treatment that we've forgotten.
Haemophilia Centre in Sheffield gave some advice about a woman in Pinderfields recently, and we had to give her DDAVP. She was having a general anaesthetic but still wanted. And they said give it subcutaneously, and they felt it was much better.
You can give it IV, subcut, or intranasally, and so it's even easier if you just squirt it up someone's nose. And the kids with von Willebrand disease find that really useful, so they can go and play rugby, football, boxing, whatever they like doing.
Any other questions? Can I just ask about the steroid? If we have somebody who comes in who's got that low platelet count, and you're saying we're giving milligram per kilogram of prednisolone, is it worth us giving that? Just as
if they're in labour,
yes.
No, you've missed a load. So it needs to be a couple of weeks before. When we audited this, we were giving it way too early in Hull. We were giving it about 36 weeks gestation, and women were going to term, and it wasn't doing anything. So we were giving more IVIG. When we brought that forward to 38 weeks, because when we were delivering later, it worked better. But if you're in labour, you've missed the boat.
Well, I think I'll just say thank you very much indeed.